Hello and welcome to a rheumatoid arthritis lecture number 2. In this lecture, we will be learning a little bit more about rheumatoid arthritis. So let's start with our first slide. Here we're looking at the pyramid approach, and this is an old approach that was basically used to treat rheumatoid arthritis. So it was used under the assumption that rheumatoid arthritis is actually a pretty benign disease, that it's not life-threatening, and that there is no mortality or morbidity that's actually associated with it. Now we know that rheumatoid arthritis is associated with mortality and morbidity, so we treat rheumatoid arthritis differently. But back in the day, what they used to do is they would start a patient on rest, physical fitness, maybe occupational therapy, and then use NSAIDs for pain relief. Then they would escalate somebody to hydroxychloroquine or gold, and then they would treat them with methotrexate or azathioprine if the previous therapies didn't work. And then finally, as a last resort, they would use experimental drugs or cytotoxic agents for refractory rheumatoid arthritis. So now we treat rheumatoid arthritis differently. Now, when somebody is diagnosed with rheumatoid arthritis, we actually initiate them on disease-modifying anti-rheumatic drug within 3 months of diagnosis. And current clinical guidelines, they do support the use of NSAIDs, but an important note that needs to be made about NSAIDs is that you need to clearly realize that they don't actually affect progression of the disease. Meaning, they're great when it comes to help with relieving pain or inflammation, but in terms of stopping cartilage destruction or modifying the course of the disease, they're absolutely useless. That's why they're only used as comfort or support therapy, but a therapy with a disease-modifying anti-rheumatic drug is absolutely a must in a treatment of rheumatoid arthritis. So let's review our NSAIDs. This is from uspharmacist.com. There's a paper on that website in references that you can read more about them, but just to remind you, in our body, we have 2 different enzymes. The first one is COX-1 and the second one is COX-2. And they are involved in the production of some prostaglandins or cytokines. Specifically, COX-2 is especially involved in the production of inflammatory cytokines. So what the NSAIDs actually do, that's why they're called non-steroidal anti-inflammatory drugs, is because they block the production of the cytokines that are involved in this inflammatory processes. So now we're going to talk about methotrexate. Methotrexate is basically a first-line disease-modifying anti-rheumatic drug for the treatment of rheumatoid arthritis. And there's so many great things about it. The first one is that it has convenient once-weekly dosing, and it has a great safety and efficacy profile. You can give it either orally via tablets or as an injection or shots. The mechanism of action in rheumatoid arthritis is actually not entirely understood, but what it basically does is suppresses inflammation and it helps stop disease progression. And then therapy with methotrexate is actually associated with a reduction in cardiovascular morbidity and mortality in rheumatoid arthritis patients. And this is important because remember we talked about how in rheumatoid arthritis you actually have increased mortality from cardiovascular disease and infections. So let's say what happens if methotrexate alone doesn't work. So what you would do is you would do a combination therapy of methotrexate plus another disease-modifying anti-rheumatic drug. And that may allow you to take lower doses of individual drugs, and it's actually thought to be more effective in clinical studies. Common side effects of methotrexate could include nausea, vomiting, hair loss, alopecia. Some of the dermatologic reactions also increased liver enzymes, and with chronic use it could lead to cirrhosis. Now, if this fails, methotrexate alone fails, you can also add on a biologic. But an important note about biologics is that especially in patients with rheumatoid arthritis, that biologics have to have a risk to worsen existing heart failure. So now let's talk about corticosteroids. What is the clinical niche for their use in rheumatoid arthritis? Well, they can be given orally in low doses, more specifically doses that are equivalent to 10 milligrams of prednisone or less. So there's a way to interconvert different steroids to an equivalent dosing. So here we're looking at 10 milligrams of prednisone or less. And we're trying to stick to as low doses as possible. Why? Because long-term chronic use of corticosteroids is associated with a vast number of different adverse effects, specific metabolic disturbances, weight gain, diabetes, also changes in blood pressure, infections, compromised wound healing, and adrenal suppression. So it's best to use corticosteroids for under a year and ideally as short duration as possible. But the great thing about them is that they appear to slow down the rate of disease progressions. Now, alternatively to oral use, you could give steroids as injections into particular joints that are actually affected by rheumatoid arthritis. And these would be done intermittently to control the symptoms of rheumatoid arthritis, specifically pain, inflammation, swelling. But unfortunately, frequent injections can accelerate the destruction of the cartilage. Destruction of the bone. So you need to limit injecting into the same joint to every 3 months. So now we're going to talk about disease-modifying anti-rheumatic drugs, or DMARDs. This should be considered for all patients because what they do, the reason why they're called disease-modifying anti-rheumatic drugs is because they actually modify the course of the disease. So as soon as a patient is diagnosed with rheumatoid arthritis, what you need to do is you need to start a therapy within 3 months of initial diagnosis. They have a potential for very serious toxicities, but they do have countless benefits. They reduce swelling and inflammation in the joint. They actually prevent joint damage. They help maintain proper function of the joint and mobility so that a patient can actually move around and enjoy all the activities of living that they enjoy to do. And they have a great impact on individual well-being, productivity, work, and in the big picture, overall healthcare costs. Generally, their onset of action is slow. They take about 3 to 6 months to work. But these specific 3, they work a bit faster within 1 or 2 months. And we're going to talk more about this. So now, how do you actually select a correct DMARD? Well, selection will be determined primarily by the physician who needs to look at the overall clinical picture. Also, pharmacists will probably look at the cost of the drug, the patient tolerance, and the ease of administration. So there are few comparative studies that are actually looking at different DMARDs, but just a simple intuitive way to think about it is that methotrexate is going to be our go-to agent because it has a rapid onset, it has a good tolerability with manageable side effects, good response to therapy, and it's relatively cheap. Other things to consider is that both hydroxychloroquine and sulfasalazine, these are also considered relatively safe and effective. Leflunomide is actually one of the fastest acting. Also, azathioprine, this one is going to be reserved for the severe disease that's unresponsive to other treatment, azathioprine. And D-penicillamine, or D-pen, this one is actually associated with a rare serious immune diseases such as myasthenia gravis. And it's also one of the slowest acting. And then finally, cyclosporin, this one is going to be reserved for refractory RA. So now moving on to biologics. This should be a familiar slide from the beginning pharmacology lectures. But as the name implies, they're derived from living organisms, and the first biologics were actually obtained directly from humans or animals, such as human blood. For example, insulin was derived from pigs or cows. But now we produce them using a recombinant DNA technology, and Humira should be familiar to you. This is a monoclonal human antibody. What it basically does, it binds to TNF factor alpha, the one that's involved in inflammatory processes in the joints in rheumatoid arthritis. And by binding to it, it virtually inactivates it. So what are some of the other targets that biologics work on? So these are the key mediators of inflammation, such as interleukin-1, interleukin-6, and TNF factor alpha. All of these molecular entities are going to be widely present in rheumatic joints, specifically in synovial fluid and tissues. And what you can actually do is you can upregulate, what they can actually do is they can upregulate their own expression through a feedback mechanism. So basically they can make more of themselves. As bad as they are, they can also reproduce through a feedback mechanism. And finally, the newest biological agents, these are going to target B and T cells, the cells of our immune system. So basically, depletion of B cells is important because B cells are going to be involved in inflammatory pathways that are basically responsible for joint destruction. And activation of the T cells is going to be important because that's also going to prevent joint destruction and inflammation. So we have these two drugs that target both B and T cells, and Orencia actually inhibits T cell activation, versus rituximab, or Rituxan as a brand name, is going to enable depletion of the B cells. And here let's talk more about rituximab. So this is a monoclonal antibody. It's used for treatment of moderate to severe RA. It's actually the newest TNF factor alpha biologic, and it's used in combination with methotrexate. So this one has to be combined with methotrexate. Adult patients with inadequate response to one or more TNF factor antagonists, this is a patient population. Basically, you would administer rituximab as an infusion of 1,000 milligrams on day 1 and 15, and you would do it in combination with methotrexate. Subsequent courses can be administered every 24 weeks, but if somebody has severe symptoms, you can space it out a little bit sooner, but no sooner than 16 weeks, and this is what's recommended by a manufacturer. And the reason why it has to be administered with methotrexate is to reduce the risk of human anti-chimeric antibody formation. So some of the US black box warnings are going to be fatal infusion reactions, hepatitis B virus reactivation, and then progressive multifocal leukoencephalopathy. So now let's look at different compounds that you could use in treatment of rheumatoid arthritis. So basically, what can we do? So we can't really do any of these. So using compounds, we can't modify progression of the disease. So the only thing that we can do would be this stage, and that would be comfort care. So two of the compounds that we could use would be this one. This one contains NSAID. It's ketoprofen, a long-acting non-steroidal anti-inflammatory drug. And if you remember these two supplements from the osteoarthritis lecture, what they're thought to do is they're going to help basically with the joint space narrowing a little bit, so hopefully you won't experience as much pain as you normally would in the destructed joint. And then this compound, P211, this one is used for soft tissue and inflammation, but it's really good for rheumatoid arthritis because by definition, rheumatoid arthritis has so much inflammation in the joint. So an NSAID here is diclofenac. It's a very fast-acting NSAID, although its duration of action is a lot shorter than that of ketoprofen. And diclofenac would actually help with pain and inflammation, and cyclobenzaprine is a muscle relaxant, but it could be beneficial because perhaps, because of the stress on the joints, patients can experience muscle aches, and cyclobenzaprine would be beneficial for that. So thank you so much, and we will be moving forward to our next lecture. This is it for rheumatoid arthritis.